Hello, this is Dr. Hausinger, and we are going to be reading Chapter 4 in your Babor book, Drug Policy and the Public Good, talking about harms and illicit use. This is coming right from the WHO, World Health Organization. We know what can and needs to be done to help reduce the burden of psychoactive substance use. Therefore, the WHO is committed to assisting countries in the development, organization, monitoring, and evaluation of treatment and other services. The harmful use of alcohol results in 3.3 million deaths each year worldwide. On average, every person in the world aged 15 years or older drinks 6.2 liters of pure alcohol per year. Less than half the population, 38.3%, actually drinks alcohol. This means that those who do drink consume on average 17 liters of pure alcohol annually. Some 31 million persons have drug use disorders. Almost 11 million people inject drugs, of which 1.3 million are living with HIV, 5.5 million with hepatitis C, and 1 million with both HIV and hepatitis C. Drugs operate within markets, and the legal market and the illegal market both have their risk factors. And later on in this course, we will be talking about legal markets such as pharmaceuticals. We have to define what harms is. Harms to the user can be separated from harms to society. So, for example, somebody that uses drugs might have chronic health problems. They might have infectious disease, which could then be transferred to somebody else. Societal harms can include property crimes, family breakdowns, homelessness, lost wages, cost to taxpayers, etc. So when we're looking at harms, there are some drugs that might disproportionately affect the user versus society. So it's important to really qualify what we are talking about. Casual relationship effects regarding policy, availability, purity, etc. So for example, there might be an increase in heroin overdoses in a place where there is more fentanyl mixed in with the heroin, and perhaps in this particular place, the policy is not friendly to naloxone or to drug testing or harm reduction agencies, okay? And perhaps there's more purity or maybe more contamination in the drugs. Okay, so we want to look at this in terms of not so much domino effect, but the cyclical nature of how policy is affecting use and society, etc. Okay. So when we're looking at the principles of assessing harm, we want to look at drug use versus the problems that accompany drug use. This is very important to tease out and differentiate, because then it will affect how we go and address the different systems that are in play. For example, systems that help the drug user versus systems that might help society or prevent crime, etc. One of the things that's important to look at is that different drugs cause different types of harm. And the authors of your chapter point out that the majority of harms associated with crime and violence have to do with the stimulant type drugs, as well as barbiturates, which are psychiatric medication, old school psychiatric medication, which can cause a lot of instability, and a lesser extent to heroin and cannabis. One of the things that this chapter does not particularly talk about, but they do talk about in the previous chapter, is alcohol. So alcohol is really left out of this chapter in terms of looking at harms. But if we're looking at it realistically, especially in the United States, alcohol-related accidents, assaults, crimes, etc., really at the top of the list, and chapter 3 of your book talked about this. Okay. So different drugs cause different types of harm, and harms from drug use can be separated from the political and social responses to use. One of the things that you'll hear me say a lot is that we have to be very careful with knee-jerk policy, because the policy could potentially, let's say that there's policy that is directed towards curbing a supply without looking at the demand and what's being used and how it's being used and who it's being used by. We could potentially create more risky behaviors and more harm to the user through policy that is seeking to restrict supply. Harm is both a subjective and objective term, largely socially and culturally influenced. Um, it's safe to say that in our country, the view of marijuana has changed a lot with public perception, and that public perception, along with research and lobbying, has led to it being more widely accepted, and we have a lot more states where it's legal both medicinally and recreationally. So that would be an example, as opposed to maybe in the 80s or a previous decade, it might not be as socially acceptable, and the politics reflect that. And so we're definitely seeing that now. Okay. We have acute versus long-term harms. An example of this would be intoxication or overdose, which is immediate, versus the effects of long-term use. And I think that you see that in particular with alcohol. Outside of alcohol poisoning, alcohol really breaks the body down system by system over time, as opposed to something like heroin, which can lead to respiratory failure pretty quickly. Okay. We also have differences with drug patterns of use and the harm potential of each drug and how the drug is being used, such as the route of administration. Your authors note that a lot of harm and risk can come when substances are used together in a polysubstance way. Compounding there. Morbidity and mortality. Many deaths that are related to drugs are not classified directly as such, and we have the drug attributable fraction. Tables 4.1 to 4.5 provide country-specific data and substance-specific data in regards to cannabis and cocaine, etc. So when you're looking through these tables, what you're looking at is the global burden of disease category, the relative risk, and attributable fractions. And it's organized by different disorders. And they will also cite the literature there too. So for example, table 4.1 in your book, lung cancer, global burden of disease. Yes, there is some evidence showing that it is carcinogenic if smoked in cigarette papers. Okay, and it gets very, very specific and goes through, heart disease, major depression. There is a link to schizophrenia, but that might only relate to those with genetic vulnerability. Okay, right. And then we go through and look at opiates, etc. So you can look through these tables and compare the different types of substances and the different types of death. So for example, with opium, cancer, there's a causal relationship, traffic injury, yes, because of impaired motor coordination, etc. Okay, and they'll also tell you if there isn't enough evidence yet to make a correlation between this drug and the outcome of death. Right. Risk relations are going to be different in different global communities based off of laws, policy, the type of drug, the purity of the drug, what it's mixed with, etc. And then we have deaths and burden. So GBD, global burden of disease, and the drug use and the circumstances of the use itself. So for example, is there intravenous use? Is it, are needles being shared? Okay. Are there compounding factors? Are substances being used in conjunction with one another? Okay. or also high-risk situations. So, for example, alcohol and drowning. Well, let's examine the different classes of morbidity and mortality. So we have overdose, which is sometimes called drug poisoning, and it tends to be more common among long-term users in the 20 to 30-year-old range, mostly male IV users with the primary drug of choice as opiates. Overdoses aren't classified as suicides without other evidence, such as a note or other previous attempts. Risk factors include homelessness, poverty, concurrent use of other substances, especially alcohol and benzodiazepines, impaired physical health, depression, and previous overdose history. The other injury category covers a lot of different things. People that are using substances are at increased risk for suicide versus non-drug users. Suicidality and drug use are risk factors for each other. So drug use, alcohol use is a risk factor for suicide, and suicide ideology is a risk factor for drug use and alcohol use. Okay. This includes traffic accidents, suicide, and physical injuries. Could include accidents, but also being the victim of an assault. Systemic violence in the drug trade. So if you're in an illegal cartel, the police are not going to be enforcing things. So there might be enforcers. We see like if we're looking at media, the wise guys type thing, or the enforcers, right? Economic compulsive violence. This would be crimes that are committed in order for the drug trade to occur. Okay. And then psychopharmacological violence would be violence that is induced from the use of the substance itself. So, for example, if someone's under the influence of cocaine and they go into a rage, okay? And it's important to note here that some drugs have a higher incidence for this than others. So, for example, cocaine and methamphetamine is going to have a higher violence there than a sedative, and that would make sense if we're looking at the qualities of the drug. Right, so those most often linked with this psychopharmacological violence are amphetamines, cocaine, barbiturates, and PCP. Whereas there's not a lot of evidence to link heroin, marijuana, or other hallucinogens to this. And that would make sense if we're looking at the quality of the substance and we're looking at the drug classifications, right? Something that is agitating versus something that is sedating. And again, alcohol is left out of this particular discussion in this chapter, but I do want to make a point that alcohol is its own beast, and we do need to speak about that separately. Okay. And you'll often notice that when we're looking at classifications of drugs, alcohol is kept in its own category. It is a depressant, but again, alcohol is its own special breed, and so we do look at it a little bit differently. Continuing with our causes of morbidity and mortality, non-communicable physical diseases. When we look at the routes of administration, there are some routes that are safer. So, for example, if you're taking something orally versus if you're taking something intravenously, because when you use something intravenously, you are bypassing the body's natural defense mechanisms. Whereas if you are taking something topically, or if you're taking something orally, or if you're inhaling something, the body has a lot of different defenses to shield the body from use. But if we're going right into the bloodstream, then we don't have that. And if we are experiencing homelessness, or in an area we don't have sanitary products or access to clean materials, then we are increasing the rate of infection even more. Okay. Now, especially in terms of opioid users, drug users do tend to be in higher levels of pain, and with opiate users, because they've been using opiates and, for lack of a better word, throwing the body chemistry out of whack, they may experience something called hyperalgesia, which is a heightened a very, very heightened sense of pain. So something like a hug or brushing against the skin, which shouldn't really cause pain, it's not something that would cause pain, can feel very, very painful. And so, especially after they stop using, they might be very uncomfortable for a while. And then your authors note that untreated physical pain might be met with self medication, or if somebody has some type of surgery and they're prescribed pain pills, they could potentially become, dependent upon that. Okay. Our next cause is mental disorders. There is an overlap in criteria here, and there might be genetics involved, and then crossovers with diagnoses as well. Okay. Psychopathology and mental health is a risk factor for SUD, and SUD is also a risk factor for mental health. So, very similar to the suicidality, which we spoke about a little while ago. And then there is a genetic vulnerability that could occur as well. For example, schizophrenia does tend to run in families. Okay. All right. Infectious disease. So, if a person is using intravenously and they have unsafe injections and sex practices, then we could potentially spread disease. Here's something that you'll see, especially when we're looking at the United Nations and WHO sites: persons or people who inject drugs. The majority of persons who inject drugs will have one or more serious diseases within 5 years of injecting drugs regularly. So, for a policy perspective, this means that we need to start relationships with users in the beginning, introduce people to safe injection practices or other methods of using drugs. This injection is by far the most unsafe. Right? One of the issues here, too, is that when we're looking at harm reduction, needle exchanges are very common. One thing we could do is we could provide pipes to people, glass pipes to people. In Seattle, they did an informal study with the police department, and they found that most people surveyed would prefer to smoke drugs, but they can't find, pipes or safe apparati, something like that, to use regularly. But there's free needles all over the place. So the People's Harm Reduction Alliance, they actually got a grant from the federal government for $4,000 to purchase crack pipes and distribute them. So, thinking outside the box, if we know that most people that are injecting drugs will have at least one or more serious diseases, we can try to help prevent that when people start using. Okay. Looking at risk factors for these harms, a lot of these are socially based and probably won't surprise you. So, housing and homelessness. People might be at an increased use for sharing needles, lack of stability, having sex for money or sex for drugs, which can open you up to infectious disease and assaults and rape, etc. And then people that are unhoused are more exposed to the elements, and they tend to have more health problems, as one might expect, including HIV. Criminal activities as well, looking at prison studies, looking at the arrest record for drug users who are incarcerated. Incarceration can be a predictor to future drug use. And so how this would affect things on a policy perspective is identifying these individuals and preventing that revolving door from occurring with case management programs, diversion programs, and connecting to the community. And then we have the public nuisance risk factors such as property crimes, traffic and other accidents, and job instability versus drug testing in the workplace. If you were to go to the Department of Corrections website, what you're going to see is, and you look at what crimes have people committed, you're going to see a lot of property crimes and not as many drug crimes. However, the majority of property crimes in Washington state are committed either under the influence of or in pursuit of drugs. Okay. And drug crimes in itself, that's going to cover things like possession, trafficking, intent to distribute, etc. So when we are looking at statistics, it's important to note, just like as if somebody passes away from drug use, it might not be directly stated it was an overdose. It could be, lung cancer, cirrhosis, or respiratory failure, etc. Same thing when we are looking at crimes. All right. So we've talked about all these harms, and we will spend more time later on looking at harm reduction. But some basic harm reduction examples are needle exchanges, safe injection sites, providing drug pipes instead of needles. Dance Safe is a Seattle-based organization, and they provide drug testing kits as well as condoms and water at raves, providing condoms. And then moderation management, MAT, medication-assisted treatments like methadone, buprenorphine, naloxone, naltrexone. Nicotine patches are a form of harm reduction. Getting a designated driver, and then first responders carrying Narcan. And we will talk about all of these in more depth later on in the semester. Thank you so much for your attention.